Welcome to Med1 Page. My name is Benjamin, and today I'm going to be talking about diabetic foot. So when you look at diabetic foot, this is basically any infection, ulceration, or destruction of the deep tissues of the foot that is associated with neuropathy or peripheral arterial disease that is found in diabetes mellitus patients. So normally what happens is that we have a core triad which combines neuropathy, someone has ischemia, infection, an ulcer. The ulcer and most of the times results into gangrene if there is no intervention, and eventually will lead to amputation. So when we look at the pathophysiology, what happens is the neuropathy is going to be, we're going to have the sensory, the motor, and the autonomic neuropathy. So the sensory is going to come from hyperglycemia, which is the formation of advanced glycosylation end products, that is sorbitol and that is fructose. So when these are produced, they are going to cause a lot of oxidative stress. And the oxidative stress in that area is going to lead to demyelination of the nerves. And when we demyelate the nerves, the transfer of impulses is going to be interrupted. So you shall have loss of pain and temperature sensation. And when this is not noticed, someone will be exposed to trauma, and the trauma is what is going to lead to ulcers. Then we have the motor nerve damage, where we have nerve damage still that leads to intrinsic foot muscle atrophy, because we all know that if a muscle is not innervated, if a muscle loses its innervation, it is going to atrophy, and that is going to lead to deformities. So when you have atrophy of muscles, things are going to be fold, and we shall have now things like the claw or hammer toes, whereby we have the flexion of a distal interphalangeal joints, and that is going to cause a new abnormal pressure on the upper surface of your foot, and when that is exposed to trauma, you can easily get ulcers. Then autonomically, we have the sympathetic fibers that are responsible for production of the sweat or oil that keeps the skin more smooth, and when the skin dries, it's going to crack. When the skin cracks, the fissures are going to be a way through which the infection will reach into the foot. Then we have Charcot foot, and this occurs when you have a neuropathy, a loss of sensation, and then microtrauma. And when this happens, we are going to keep on hammering these joints, and the pressure that happens to these joints is going to destroy them, what we call the Charcot arthropathy. And at the end of the day, we are going to have, for example, we can have the midfoot collapse, which will lead formation of what we call an rocker bottom foot. So when you look at the plantar surface of the foot, it has an arch. But when you have destruction of the joints due to this Charcot foot, we're going to have an abnormal plantar pressure, because the foot is going to flatten, it's going to rock. Well, we have what we call a rocker potential, and I'll show you a picture about that. It's going to cause the abnormal plantar pressure, and those areas that are not actually mostly used for stepping are now going to be used for stepping, and it's going to lead to ulceration at that area. Then living along the neuropathies, we have the ischemia or the vascular disease that happens. We have the macroangiopathy and the microangiopathy, and the macroangiopathy is going to come from atherosclerosis, while we have sclerosis of the big vessels, and that's going to lead to decreased perfusion. This is basically peripheral arterial disease that is happening here. And because of that poor perfusion, we shall have poor healing. And when we have wounds and ulcers, necrosis will set in. Then microangiopathy is due to the thickening of the capillaries, leading to tissue ischemia, and also that will eventually lead to delayed healing. Then we have here the homeorological mechanism, where we have increased LDL, very low density lipoproteins, fibrinogen, and Willebrand factor, and decreased prostacyclin. This is going to cause a hypercoagulable state and lead to formation of small thrombi. And this thrombosis is what is going to cause the gangrene in the distal end of the foot. So, when we look at infections are going to be a predisposition as well as an outcome. So infections can lead to an formation of an ulcer, but the ulcer will also lead to infection. So it's kind of a loop. So infection can cause breakdown of the barrier and ischemia, and because we have impaired immunity in these people with diabetes, we end up with soft tissue infection or osteomyelitis, and that's going to cause gangrene. Then we have the trophic changes whereby we have collagen and chondrotic glycosylation because we have a lot of glucose in the blood. So there is non-enzymatic glycosylation of these tendons. And when these tendons are glycosylated, they're going to contract, we're going to have contractures. And we can have deformities like the equinox. And these are going to also increase the plantar pressure on these areas, and we're going to have formation of calluses, and these calluses predispose someone to getting ulcers. Then now, the ulcer progression now is going to come from a combination of the neuropathy, the ischemia, and the pressure. When all these factors are acting together, that's going to be formation of an ulcer. Ulcer is going to cause for an infection. The infection will lead to gangrene. And it's going to be all of this is going to be compounded by poor glycemic control, deformity, and repeated trauma. So these will be working in the background alongside the neuropathy, ischemia, and pressure to form the ulcer. So, in summary, what is going to happen is we have neuropathy that leads to deformity and sensory loss. This exposes one to trauma, and when you have trauma, there is formation of the ulcer. The ulcer is ischemic because of poor blood supply. We have delayed healing. The delayed healing leads to infection, gangrene, and the gangrene will lead to amputation if we want to save a person's life. So, the trophic changes on Charcot foot are going to amplify pressure points because they're going to change the way the foot is oriented. And that is going to create new pressure points and the recurrency of the ulcer. So most of the times, we may need to actually change or undo these deformities so that we don't have an ulcer recurring. So we have some of the risk factors of these are going to include the poor glycemic control, the duration of diabetes, smoking, when no smoking worsens peripheral arterial disease, or it worsens the formation of atherosclerotic plaque in the arteries. We have obesity, we have previous ulcer or amputation. Someone who has been amputated before has even a higher chance of having another amputation. Foot deformities like the Charcot foot, the claw toes. We have inappropriate footwear and visual impairment because this person may not actually has to rely on their eyes to see that they have wounds if they have a neuropathy and cannot feel anything. So investigations we can do, we have a bedside where we can do a blood glucose, that's or the HbA1c. And this is very important because high HbA1cs have been associated with higher occurrences of diabetic foot and a higher risk of amputation. The neuropathy tests, we want to use a monofilament to check for the sensory, the sensation. We want to use a vibration using the tuning fork, that's the 128 Hz tuning fork, and also check for ankle reflexes. This is all assessing the neurons. Then the vascular, want to palpate the pulses and want to do ankle brachial index. So we find that whenever we have an ankle brachial index less than 9, that is the ratio of the pressure at the ankle to the pressure at the brachialis. If it's less than 9, then you have suspicion of occlusion, that is peripheral arterial disease. And when it's less than 3, poor wound healing is going to occur. And some people say when you have a top pressure, sometimes you can just measure a top pressure. If it's less than 30 millimeters of mercury, we have poor healing potential. Then in the laboratory, you want to do CBC, ESR, CRP, you want to do a wound swab or culture, you want to do renal function tests. That is if before we are going to do the contrast studies, because you may need contrast actually to visualize these to visualize the arteries and see if where they're at the point of occlusion. Then imaging, we can do X-ray of a foot where we can see gas, we may see osteomyelitis, we may see the deformity, we may see calcification of extremity vasculature. Then on Doppler, you can do arterial flow. On MRI, it's good for assessing soft tissue abscess as well as early osteomyelitis. So we have the type of ulcers in diabetic foot. Some of the ulcers are going to be neuropathic, ischemic, or mixed. So when they're neuropathic ulcers, they're going to be caused by the loss of sensation, which exposes one to pressure trauma. And it's going to be typical at the pressure points, that is on the plantar surface. And it is going to, when you touch that foot, it's going to be a warm foot, it's well perfused, and the ulcer is going to be painless. This all point to more chances of this foot being neuropathic. Then we have ischemic, whereby we have arterial insufficiency. This is going to occur to areas that are poorly perfused, that have poor veins, and these are areas at the extremities where we have maybe like a small distal artery that is going there to supply that area. So those areas at the margin of the foot or the toes are going to be the ones that are mostly ischemic. And sometimes these lesions are going to be cold. When the feet are touched, they are cold, and the ulcers may be painful. But it's also not uncommon for the ulcers to be actually painless. Then we can have punched out margins. The neuroischemic, which are mixed type, we have neuropathy and ischemia, and it can occur anywhere on the foot. It may be cool, it may be pale, and may be painless. So we have the Wagner classification of diabetic foot, and it grades diabetic foot from grade 0 to grade 5. Those are 6 classes. So grade 0 is when we have an intact skin, and that is a high risk. And grade 0 is when we have an intact skin in a high risk foot. Is a patient who has diabetes, who has high blood sugar, but actually the skin is still intact. Maybe they just have calluses. Then type 1, the grade 1 is when we have a superficial ulcer. Grade 2 is when we have a deeper ulcer that exposes the tendon, the bone, or the joint. Then grade 3 is when we have a deeper ulcer with an abscess or osteomyelitis. So now grade 3, the bone is involved, or we have an abscess. Then grade 4, we have localized gangrene for our foot. And then grade 5 is when we have extensive gangrene, whereby the infection has spread through the different fascia layers of the foot, and it is spreading. That is grade 5. So we have the complication with diabetic foot, and that is cellulitis, that is abscess formation, osteomyelitis, gangrene, sepsis, amputation, and recurrence of the ulcers. So when you go to the management, it's going to be a multidisciplinary management where I want to involve an endocrinologist, a surgeon, a podiatrist, an infection control, and a vascular specialist. So strict glycemic control is important, and normally when these people have a diabetic foot, want to use actually insulin. When we have offloading, whereby we want to remove pressure or want to remove pressure from that area where we have the ulcer. There are specific boots that have been used. I can use what they call the total contact cast, and this is going to help make sure that place that has the ulcer is not touching the ground, it's not being pressed against, and that will help enable that place to heal. Then you have local wound care where we do debridement and moist dressings. We have to give antibiotics for infection control, that is empirical broad spectrum, and maybe culture based, but most of the times in diabetic foot we have polymicrobial. It's a polymicrobial kind of infection, so we treat empirically broad spectrum antibiotics. Then we can do revascularization, that is an angioplasty or a bypass if the ischemia is significant. We can do amputation if the limb is non-viable or infection threatens life. So normally when you talk about diabetic foot management, we have this acronym foot care, and gives a bit of explains or gives us an overview of most of the important things that we need. So footwear is important. Someone should wear closed shoes, but with a good circulation. Closed shoes with maybe some perforations to allow entry of air, that is to prevent someone from getting the diabetic foot. And then you have to offload these areas of pressure, or the areas that are developing ulcers. Want to optimize the glucose, want to treat the infections, want to do something about the circulation. It can be to assess or restore it. Want to avoid trauma, regular inspection, and then education of the patient is very, very important. Then surgically, we want to debride the necrotic tissue. We drain the abscesses. We can do minor amputations if it's toes, or we can do desaturations, and we can have major amputations if it is extensive necrosis or systemic sepsis. So the prevention is very important, and it is key for all diabetics. We want to do daily foot inspection, that is in a mirror or by a caregiver aid. We want to get the proper footwear, that is soft, wide toe shoes, not shoes that squeeze everything together, because they're going to cause pressure, and this patient is not going to feel the pain. They will never know. They want to avoid barefoot walking. Foot hygiene is important. You want to keep the feet clean, dry, and moisturized. And you want to avoid putting the moisture between toes, because that moisture there is going to cause fungal infection of everything, and then result into formation of ulcers in there. You want to do regular podiatry checkups. You want to report early reporting of the blisters or cuts, smoking cessation, tight glucose control. And it's very important to know that most diabetic patients are even not advised to cut their own nails. They are required to do it by a podiatrist, because they could actually traumatize themselves, and if they're not careful, that could be the beginning of a cascade of events that leads to loss of a limb. So I've discussed some of the important issues when it comes to understanding where diabetic food comes from, and I hope you have enjoyed this video. I would encourage you to share it with a friend, like and subscribe, or leave a comment. Or if there's something you want me to explain, I'll be ready to do that in the comment section. My name is Benjamin, and have a nice day.